You're neatly dressed. انتوا سنة كم كده؟ مين اللي أعلى من رابعة ومين اللي رابعة في السنين؟ أعلى من رابعة يا فهد. 6 years.
أنا برابعة.
لا في رابعة تاخد 2. صوتي حيسمع هذا ما هو شغال؟ طيب في رابعة تاخد محاضرتين.
احنا عندنا روتيشن كان.
Okay, I'm ready.
بسم الله الرحمن الرحيم. نرحب بكم أيها الإخوة في هذه الدورة المصغرة للتعريف بعلم الأشعة وما فيه من أشياء قد تفيدكم في اختيار التخصص والترغيب فيه. وإذا كان هناك أي استفسار أو تساؤلات لضيفنا الكريم، نعرف بضيفنا الكريم الدكتور سطام سعود عبد الله النجاوي، أستاذ مشارك بكلية الطب قسم الأشعة، مكان عمله بمستشفى جامعة الملك عبد العزيز بجدة، وله من الشهادات العلمية البورد الأمريكي للأشعة والزمالة الكندية للأشعة والزمالة الكندية لأشعة المخ والأعصاب. فرحبوا معي بالدكتور سطام ولتفضل مشكورا.
شكرا جزيلا. Can we just switch off the light please? خلاص هو كم
switch it off.
يعني almost في نور جاي من برا أصلا. طيب السلام عليكم. The idea of this session, inshallah less than half an hour, is to take you through the history of radiology and how does radiology impact your patient management. Basically, imagine with me that you are in the 1950s, late 1950s. You are a physician, a respirologist, sitting in his own clinic, and a patient of yours walks in. He is a 60 years old man, chronic smoker. He smokes 2 packets a day, who has lately developed a cough. But it's a different pattern than the usual cough that he usually has, with some tightness of the chest and some productive yellowish, bloodish sputum. And you examine him and you find some swelling, maybe like a lymph node in the supraclavicular area. Your main concern is, does he have bronchogenic carcinoma or no? Right. So you ask the patient to go and get a chest x-ray. This is 1950. The patient on your office is actually in the middle of the hospital, near the lobby where the coffee shop is and the gift shop is, and it's a very nice area. The patient has to leave your office, goes to the back side of the hospital, walks out of the hospital to a separate building where it has the laboratory, the radiology, the laundry, the kitchen. It's all the sort of ancillary services. The minute he walks into the radiology section, a strong stench, sort of chemical smell is in the place, and it's dark. He goes, he gets the chest X-ray done, and he comes back to you and he shows you the X-ray, and the X-ray looks like this, and you look at it and say, but what's happening in here? Well, there is something wrong. This is a normal lung, and this is not normal. So he said, well, I'll tell you what, let's go to the radiologist and see what does he think. So you take the chest X-ray and you go to the radiologist and you give it to the radiologist. And the radiologist tells you, well, you know, that's not normal. Well, okay, I know it's not normal. So is there cancer in it? Wallahi tara, possible. Because I don't see the mass, but maybe it's hidden in this opacity. Type. Do you think there are any hilar or mediastinal lymph nodes? Well, you know, برضو possible, because the hilum and the mediastinum are not seen in here, but there is possibility a lymph node. Do you think he has pleural effusion? Well, I cannot rule that out, because really I don't see the costophrenic angle. So you take the chest X-ray and come back to your clinic thinking, well, he was not of any help at all. I left the clinic with certain questions in mind, and I come back with the same questions unanswered. So he was not of major help. Fine. Let's move this scenario to 10 years later, in the sort of mid-60s, where ultrasound came in action. Another colleague of yours is on call. Can you switch off your mobiles, please? Fine. Another colleague of yours is on call, and a patient comes, a 30-year-old lady, woman, comes to ER with lower abdominal pain, a bit of temperature, a bit of leukocytosis. She gets examined by the clinician in the ER. I say, well, I think she has appendicitis. But you know what? We have a next room for ultrasound, and the radiologist is there. Let's have a quick look and see how big, and is it a ruptured appendix or appendicular abscess or just plain appendicitis? And actually, when the radiologist does the ultrasound, he sees a normal appendix. And he tells you, listen, this is not appendicitis. This is a normal appendix, but she has an ectopic. She is pregnant, and there's an ectopic, and there's some blood around the ovary, and it's a totally different story. So radiology has changed now the patient from going into appendectomy, into the surgical ward, to a gynecology ward, where basically being treated by the gynecologist. Can we just close this door and... Thank you. لو تكرمت, just put a كرسي عليه ونخلص من الموضوع. فبasically change the patient management from going into appendectomy by a surgeon into going to the gynecology ward to be treated by ectopic. So here radiology has inflicted a change. Same thing comes when the patient has upper abdominal pain. Is it cholecystitis? Is there a gallstone? Is it pancreatitis? Is it renal colic? Because after all, the patient will say بطني بتوجعني, and the clinical examination, tender abdomen. So ultrasound made a change in patient diagnosis and diverted patient management in certain lines. Let's come back now. Let's go forward now to the 70s. Another patient of yours come with the same history بتاع ال 60-year-old اللي جاك قبل 10 سنين. Now he is complaining of cough, he's a smoker, blah, blah, blah. You do the chest X-ray. However, this time the chest X-ray actually is in a department next to you because we frequently use it. So he doesn't need to leave the hospital. And it's actually more bright and nice colors. So he gets the chest X-ray and you look at it and says, gosh, you know what? 15 years ago I had a similar patient with the same chest X-ray. Let's see what the radiologists think. هتروح تقول له, does he have a lymph node? Is there bronchogenic carcinoma? Is there ascites? هقول لك, well, listen, this I cannot answer from this chest X-ray, but we'll do a CT scan. And he takes him to CT scan and do the CT scan. And the answer comes, well, you know what? Yes, there's an endobronchial lesion. وترى الendobronchial lesion موجود في apical posterior segment of the upper lobe. So when you do your bronchoscopy, do your brush biopsy there. And by the way, there's not only ipsilateral lymphadenopathy, there's subcarinal lymphadenopathy, and contralateral lymphadenopathy, and effusion. And you know what? When we scanned the upper abdomen, there's a lesion in the liver. I think it's already metastasis. You come back to the office and you have all the questions that you were thinking of and the questions that you were not thinking of answered. It's a totally different ball game. Now, we tell you what is the diagnosis and what to do because we told you it's metastasis and what stage it is and what line of therapy the patient should receive. Bye. But I say, well, you know what? This lesion in the liver looks rather odd. Does not look classic metastasis. And the patients, everything is fine about him. طبعا أنا أعتقد إن this lesion hemangioma. It's a benign incidental thing. هقول لك, well, you know, إذا كان الديسيجن هيختلف, هتقول لي yes هيختلف لأنه staging is different. Look, listen, I put a needle in it, I'll take a biopsy. I put a small needle, and the tip of the needle is as small as the tip of my pen, and I take a biopsy and send it to histopathology. And the pathology comes back adenocarcinoma metastasis from an adenocarcinoma of the lung. Well then, gosh, طيب مشكلة إنه الراجل ده, now we don't even manage it to غيرنا diagnosis, we actually confirm it histopathologically. This is all by radiology. طيب بس الراجل ده is 60 years old and he had previous 3 heart attacks. Cannot tolerate surgery. Resection this lesion means 6 units of blood, 3 or 2 weeks ICU stay, major surgery. I don't think he will survive this. Tell you, don't worry. The same needle I use, they have a similar needle, Liha. I put it in the same lesion. This needle, the second needle, I connect it through a wire to a generator, and I generate a high frequency. The tip of the needle becomes so warm, and it radiates a lot of radio frequency, it burns the tumor. زي ما بتعمل في الميكروويف. حط الميكروويف كل ما سخنته لغاية ما ممكن تحرق العيش. I can, the more I put the energy, the more I cook this lesion and change the diameter of the burn I get. That's called radio frequency ablation. So you don't have to worry about your patient. You don't know how to manage it. We'll manage him for you. We diagnose him, we stage him, we treat him. So Allah, radiology is quite different. But the next step comes in wallahi, a patient comes with a frontal, with headache. And is it MS? With, headache and blurring of vision. And some numbness. Is it MS? Is it just headache? Is it tumor? We don't know. So you do an MRI. And the MRI shows a lesion in the certain area in the brain. Well, we need to take this lesion out. It looks malignant. But, I'm Salih or I'm Bakur, this lesion is an area in the brain that is critical. And when we do the surgery, we might be able to take it all, but we might not be able to take it all. And if we take it all, you might be coming out with a neurological deficit. ممكن تفقد النطق، ممكن تفقد الحركة. إحنا ما عارفين بالضبط إيش اللي ممكن يحصل في الجسم. What do you think is the option of the patient? يعني تيجي تقول لواحد والله أنت ممكن تصحى منها مشلول، ممكن تصحى منها ما تتكلم. طب هو ما عارف يحصل له إيش. فالديسيجن making of the patient is very difficult. But with radiology, now we can tell him, put him in the MRI, we'll show you the tumor, we'll show you the lesion, and we'll ask عم صالح ولا عم بكر to do certain movements. عم صالح نبغاك تحرك، هو في الMRI، حرك يدك، وقف يدك. Now as I am talking to you now, we're all awake and we're all perfusing our brains. And I'm perfusing more of thought and speech, and you're perfusing more of hearing and understanding. صح؟ Preferential. So when I do hand movement, I'm taking more blood to the hand. When I see something and I stimulate my vision, I'm taking blood more to the cortex of the vision. So when I ask the patient to do certain movements, I can see where more blood is going. So I will, هذه الهاند area. This is the vision area. This is the auditory area. طبعا it gets complicated when I make you listen to something. Or لما يكون فيها emotional involvement أو see something. I can show you a picture that makes you laugh. I can show you a picture that makes you cry. I can make you listen to آية قرآنية تبكيك. وممكن أسمعك نكتة تضحكك. It depends what are things I'm stimulating and how am I stimulating it. Is it pure motor ولا pure sensory ولا emotional ولا rage ولا anger, and what kind of sensation. By this I can map the brain. So the patient, before he goes to surgery, I tell him, يا عم صالح, yes, we can take it all. Oh, by the way, when we take it all, الحمد لله ترى يدك هتتحرك، رجلك هتتحرك، يمكن يصير شوية ضعف في النظر في عينك اليمين، لكن عينك اليسار كويسة. Now he can make a decision. So we map the brain for him. So radiology, as you can see, moved from basically being, ما احنا عارفين عنده cancer ولا لا، أو ترى ما احنا عارفين ما أعرفش إيه، into what are your questions? All the answers are available. Patient comes with diabetes. 25% of the Saudis are diabetic, with ulcers in the feet, difficulty in walking, pain, basically stenotic atherosclerotic vessels. We do the angiogram, we diagnose with the stenosis, we put the balloon angioplasty, كلكم سمعنا عن balloon angioplasty, and we open the vessels and we put a stent if they are not opened enough. Patients coming with brain bleeding, we put the catheter in and we close the bleeder with small coils, لفافات platinum. So radiology has moved from being just a diagnostic, not very helpful, into a major cornerstone into patient therapy. I tell you one example. بكرة حتكونوا كلكم في المستشفى إن شاء الله يوم السبت. شوفوا لي مريض واحد متنوم في المستشفى ما هو مطلوب له some sort of radiological investigation. Not a single one. That tells you how important is radiology. في 100 مريض متنوم ما شافوه الانترنست because it's a surgical case, or ما شافوه dermatologists, or ما شافوه ophthalmologists, لأنه ما هو مجالهم، المريض ما يحتاجهم. لكن not a single one did not have a chest X-ray or some kind of radiological investigation that tells you it's a cornerstone. So now الother piece اللي تلاحظوها just common observation. أي مرة يجيبوا فيها دعاية لأي بلد يجيبوا صور البلد والكورنيش بتاعها والعماير، الهندسة اللي فيها، النهضة العمرانية. ويتكلموا to science يجيبوا لك المستشفيات. The first thing that comes what? Somebody looking at an X-ray, a machine doing a CT scan. Enough said. يعني people have recognized that when it comes to the cream of medicine, it's radiology. I'll show you some of the images because this is not what we look at now. I'll show you what we look at now. This is how we look at things now. It's a 3D simulation. You can see that this is the cervical spine, and these are the carotids, and the stenosis, and the narrowing, and the calcification. This is CT scan. This is how we look at the heart. It's not looking at cross-section and vague images anymore. We don't use films anymore. It's all computer-generated. This is how we look at the abdominal vessels, the abdominal aorta, the vessels, the bifurcation, the lumbar spine, the collapsed vertebra. And that's routine. Now I'll show you what is not routine, but where is radiology going? So that when you are applying to radiology, you know what you're expecting. This is how you are going to be looking at the brain. Oops, ليش فصل؟ This is how you're going to be looking at the brain. This is how you can slice and dice the brain in every single angle you need without even touching the patient. 3D simulation of the brain. You are better than me in this because you are a generation that is raised using computers and playing and games for computers. That this is part of what you're doing. Like for me, it's a new technology. However, this is the future of radiology. Now, I'll give you another example. You want to look at the vessels? This is how you're going to be looking at the vessels. You can fly through the body, up to bottom, the heart, the thoracic aorta, the abdominal aorta, the bifurcation, the thigh, the knee, below the knee, to the toes. This is the future of radiology. This is real cases. This is not computer-generated images. This is MRI. You want to look at the heart? You want to see it functioning? Here it is. You can see every single beat. You can see the motion of the liver. You can see the breathing. You can see the lungs. And this is actually 2007 technology, let alone by the time you become a radiologist, which is, 2015 or whatever, how things are going to be. I'll give you an example. You want to look at coronal? This is how the breathing is and the liver is, and let me enlarge this and play it again. So radiology has changed actually from being the plain radiography into the computer-generated. Now, is that because we are smart as radiologists? Well, I believe only people with high IQ become radiologists. Only the people who are really, really intelligent can see the vision of medicine and follow the light into radiology. Tamam? But the truth of the matter is radiology has moved from the back side of the hospital to the front side of to the front gate of the hospital because of the computer science. يعني the huge jump that has happened in telecommunication and computer science over the last 50 years, and us being dependent on technology, it brought us with them. So thanks to computer scientists. I'll give you one last piece of information that is also helpful, because one of your colleagues here mentioned, radiology has no on-calls. Well, radiology has on-calls, but what you have said is absolutely true, in the sense, one of your friends become a radiologist, and he becomes a musculoskeletal radiologist, and becomes a really, really good musculoskeletal radiologist, but he gets hired by أرامكو في الشرقية. And I'm here في جامعة الملك عبد العزيز في جدة. And I have a case of a knee pathology that I really have no idea what's wrong with the patient. But I know him, and I know he's good. So I'll pick up the phone. كيفك محمد، اخبارك ايه، ان شاء الله طيب، ترى عندي حاله انا محتاج فيها باخذ رايك فيها. طيب بعت لي هي أنا على الايميل بتاعي كذا كذا، على الويب سايت الفلاني، اديني الادرس بتاعه، بعت له هي. يكلمني سطام، ترى والله شايف كذا وشايف كذا، ترى هذا معناته انه عنده كذا وكذا وكذا. طيب thank you very much. I got free teaching. The patient got the right diagnosis. He got the expert report without even moving a finger, without leaving the place. And that's improvement in medical care and improvement in education. استدلت عليه. ثاني يوم اديته حاله، ثالث يوم اديته حاله، رابع يوم قال لي بس ترى اقول لك انا هنا مشغول. لكن listen, you really have nice cases and it seems like you need help. I'm willing. I have a computer station at home. Just send them to this website. And after I finish my work at home, I can view them. I can give you an opinion. ثاني يوم تفتح الإيميل بتاعك الريبورت مكتوب. But I don't do this for free. Okay, fine. We make a deal with you. اعتبر نفسك شغال بعد الظهر معانا وهذا contract معك part timer. So he works and he gives me the expert opinion without me needing to hire a new radiologist, without me needing to send films, without the patient needing to leave home or go to him, what an expenditure, and that's improvement in healthcare, and that's teleradiology. Now what allowed us to do this is called PACS, Picture Archiving and Communication System. Picture Archiving, أرشفة الصور, and Communication System, وتناقل الصور. نظام أرشفة وتناقل الصور. That we don't print film, it's all on the computer. I see it in my office, you see it in your clinic, and he sees it at his home because it's like the internet. What's beautiful about, more than this, is that if you can report it from Aramco, you can report it from Dubai, you can report it from New Delhi, you can report it from Shanghai, تلف اللفة, you can report it from Hawaii or Toronto or London. As long as it's available, I'm almost done. You can report it anywhere. And if you can do it from home, you don't have to come to the hospital. So that means that your obligation to come into hospital is minimum. After 5 o'clock, you switch your pager off if you're not on call. Nobody will be calling you to come to the hospital. You can go and dine in Chili's every night. Tamam. And you get paid exactly the same, if not more. The beauty of radiology, it is the science-driven field. It is the core, the cream of medicine. It is where you actually make change in patient management and cure, and in the same time, maintain a superb quality of life. Thank you very much. 5 minutes for questions. Right, تفضل.
Thank you, Dr. Sattam, for this nice view.
افتحوا النور لو سمحتوا.
It's been clear that the radiology is developed so many more than before. So let's see if there is any question, something not clear for you.
تفضل.
Okay, Mohammed.
Interventional radiology. ثواني. Intervention. Oops, that's طب نفسي. And I'll leave this for you guys later, huh? Who was asking the question? Interventional radiology is basically dealing with the catheters, the drainage. Patients who come مثلا بobstructed kidney, or patients coming with obstructed biliary system, or patients coming with a vascular problem, stenosis or bleeding. You put some kind of catheter, whether it's biliary catheter or renal catheter or vascular catheter, so that you remove the blockage, or you drain the abscess, or you open the obstruction. That's interventional radiology in general. In general, radiology you do 4 years after you graduate. خلصوا medicine, سووا internship, تقدم على residency program for radiology, which is 4 years. You become general radiologist, استشاري أشعة عامة. بعد كده تعمل التخصص subspecialty, التخصص الدقيق, which varies from 1 year to 3 years حسب التخصص. You can do chest, cardiac, musculoskeletal, interventional, neuro, pediatrics, whatever you want.
Okay.
أحمد جفري هاوس أوفيسر. دكتور ما أدري أنا سويت تقريبا 8 شهور الحين. internship شفت في كل التخصصات راديولوجي أكثر ما شفت التخصصات نفسها. لكن التيلي راديولوجي هل تشوف إنها فكرة تخوف شوي؟
من ناحية
إنه حتشكل خطر بالنسبة للناس اللي حيكونوا new applicants.
no يعني إنه والله تقلل احتياج الناس للراديولوجي. no ارتاح جدا طمن جدا. وزارة الصحة إحصائياتهم حقت 1425 الحين اختلفت 28 احنا صحين كانوا 22 طبيب وطبيبة سعوديين في كل المملكة في وزارة الصحة، في وزارة الصحة، يعني يشيلوا الحرس والجامعة كده. فالصحة كلها فيها، قلت الحين صاروا الدبل، صاروا 40. احنا 28 مليون، يعني صاروا 40 معناته لكل نص مليون في طبيب واحد سعودي في الأشعة. There's plenty of work. أنا أقول لك حاجة، الآن أرامكو من 28 طبيبة وحاجة زي كده صاروا 8. التخصصي is dying في الرياض إنه يكون في ناس يجوا يشتغلوا عنده. الجامعة إحنا نبغى ناس يجوا يشتغلوا عندنا في كل حتة فيه. The demand for radiologists is huge. But إحنا ما نبغى حي الله، نبغى اللي كويس يجي عندنا، اللي مو كويس ما نبغى يجي. طب بس ندي فرصة لأحد تاني.
طيب
تفضل.
خالد البلاع من جامعة الملك سعود في الرياض. دكتور أنا ما أدري وش الفرق بين الراديولوجيست مثلا مسكوسكليت الراديولوجيست والفرق بينه وبين مثلا الروماتولوجيست ولا الأورثوبيدكس، لأنه دكتور يعني كلهم they can read X-rays MRI and they can diagnose from. طيب يعني إيش الجاب؟
أنا I can drive a car بس أنا ماني عبد الله بخشب. That's the difference. عارف؟ That's the difference between a professional driver وممكن أمسك وأسرع بالسيارة شوية which is not safe and I don't advise it, but I'm not a rally driver. So I will miss a lot. I will make an accident. I will interpret the image. While professional driver will not do this. So a radiologist زي ما أنت تحين أنت في سنة كم أنت؟ رابعة. طب رابعة تحين you can diagnose pneumonia. واحد جاك وبتكح you can diagnose pneumonia. But you're not like a specialist respirologist. You don't know about the details of the pneumonia, the type of the pneumonia, the response of the patient, the management of the patient, the follow-up of the patient, the risks involved in it. فthat's the difference. أنا أقدر أشخص واحد عنده cholecystitis لكن I cannot do cholecystectomy. ده الفرق. في an expert opinion وفي a general opinion that we all obtain by our general knowledge in medicine. الزميل هناك بيقول لنا وقفوا. طب أقول لكم حاجة. Let's stop and we can talk outside. Thank you very much.
Thank you دكتور سلطان.